say something. Hi, good afternoon, everybody. Today is our second session of webinar. We're going to talk about arrhythmia, and this time, last week, we actually shared slides on how to diagnose arrhythmias. And of course, today we are going to actually talk about the treatment of arrhythmia. And yeah, Dr. Nizar is here with me. Dr. Nizar is a consultant electrophysiologist, so he would be quite an expert on arrhythmia. So we start with the session now. Can you see the slides, Nizar?
Not yet.
Not yet?
Not yet.
Oh, let me just...
I'm seeing you now at the moment.
Okay, I'm going to try to share this. Okay, let's see. You hold on. Okay. I'm going to share this. Okay, can you see the slides now?
Okay, now I can see the slide.
Okay. Okay, let's
go
start.
to the next slide. Yeah.
Okay.
All right. Okay, I start. Hi guys. Happy that you can join us on this Saturday afternoon. What I'm going to talk today is, well, last week we have looked at how to recognize arrhythmia, and that is usually or generally through ECGs. But what we'll do today will be talk on how to treat them, particularly in emergency situations. So I'll be talking about anti-arrhythmic drugs in emergencies, management of acute atrial fibrillation as an example of how to manage arrhythmia. AF, as you know, is the commonest arrhythmia around. And we'll talk about cardioversion and defibrillation. And lastly, we'll speak a little bit about another mode of therapy for bradycardias like temporary and permanent pacemakers, as well as a method of treating tachyarrhythmias, that is cardiac ablation. I'll not be talking about cardiac surgery for treatment of arrhythmia. There are very few centers in the world that does that, and we do not have a center that does cardiac surgery for arrhythmia in general. Next slide.
Okay, hold on, please. Okay.
So we start with bradycardias. Okay. When you have bradycardia, the thing to do would be initially look for the cause of bradycardias. Quite often bradycardias are due to some other conditions. For example, raised intracranial pressures, poisoning, or an infection or sepsis. But when you have bradycardias and you've identified that the bradycardia is probably causing some detrimental effect to patients, the first thing that you tend to use is atropine. And then if atropine doesn't work, you will rely on infusion of dopamine or adrenaline. We'll talk about each of these. Shall we go to the next slide? Right. Atropine works by increasing the heart rate when atropine blocks the effect of the vagus nerve, and therefore the sympathetic system becomes dominant. So the first drug of symptomatic sign of bradycardia is atropine. There are certain precautions that you will have to consider in people with myocardial infarction and hypoxia. Atropine will increase oxygen demand, and you may actually worsen the ischemia if you increase the heart rate. Doses less than 0.5 milligram may cause a paradoxical slowing of the heart rate. So you have to be aware of that possibility. Anything to add, Betty?
No, actually, I think atropine is a very effective drug in treating sinus bradycardia. The only problem with is sick sinus syndrome, it's most times not helpful at all. In inferior MI with bradycardia, atropine does work, but I think we use atropine mostly in patients who have very useful in patients who have what you call it, vasovagal. Now you will see a lot of vasovagal patients sometimes when they're in pain after a procedure, their blood pressure drop, their heart rate drop, and atropine is one of the most effective drug. And of course, you need to start on IV drip at the same time.
Right.
Uh,
The
yeah.
effect of atropine doesn't last very long. So if you need to, if you need to sustain the effect of the increased heart rate, then you may need infusion of dopamine or adrenaline. The dose of atropine is 0.5 milligram every 3 to 5 minutes, and the maximum dose is 3 milligrams. Next slide.
Sometimes, yeah, best to wait. How about isoprenaline, Nizar?
Yeah, you can use isoprenaline as well, although it's not a very common drug to have in the
Yes.
wards. Yeah. So dopamine is an agent that can increase the heart rate as well. The trouble with dopamine is it is dose dependent. So a certain dose must be given to achieve an increased heart rate. It is the second line drug for symptomatic bradycardia. And again, because it may cause tachyarrhythmia and excessive vasoconstriction, you have to be aware of that sort of side effects and consider the effects of dopamine on the patient. You must not mix dopamine with sodium bicarbonate because it can crystallize. And the infusion of dopamine is between 5 to 20 microgram per kilogram per minute. You have to give a minimum dose of 5 before it will have an effect. The alternative, which is next slide. Yeah, but
I've never used dopamine to actually for
increase heart rate.
tachycardia actually. Yes.
Because I think that's
because
the reason for it. It's available.
Yeah.
It's easily available.
Right, it's very easily available. Yes. Yes,
Adrenaline or norepinephrine stimulates the adrenergic receptors. And one of the things that the advantage of adrenaline is not dose dependent. It may also increase myocardial ischemia, angina, and oxygen demand. The doses are 1 milligram, usually diluted in 10 mils, every 3 to 5 minutes. And the infusion dose is 2 to 10 microgram per minute. Can also be given endotracheally if you have an endotracheal tube already inserted. And the dose is 2 to 2.5 times the normal dose. Occasionally in situations like, for example, anaphylaxis, you can give this in subcutaneous or intramuscular, 0.3 to 0.5 milligrams.
Next slide.
Next slide. Okay, the next group of drugs are those that we use for tachyarrhythmias. And in general, you will recall tachyarrhythmias are divided into the broad complex and the narrow complex tachycardias.
Yeah, we discussed that last week. Yeah.
The last week, yes. So the first two, adenosine and verapamil, are going to be used for the narrow complex tachycardia, while miodarone, lidocaine is for patients with broad complex tachycardias. And magnesium sulfates are usually for those who present with torsade or polymorphic VT that you think or you consider hypomagnesemia as a cause. Shall we go to the next slide?
Okay. And this we can safely give magnesium to anyone, right?
Yes, you can, but generally speaking, you tend to give it in people with broad complex and polymorphic VT. Yeah.
Okay.
So one of the things that you can do before attempting drugs to terminate tachycardias is to do Valsalva maneuvers, right? And the standard or the old way of doing the Valsalva maneuver would be to blow, let's say to blow into a 10 cc syringe for about 15 seconds. And then you stop and wait and watch for 45 seconds. And then you repeat that again. But the modified Valsalva maneuver, you do the same thing. You try and blow into a syringe for 15 seconds, and then you put the patient's head down and put his feet up by 45 degrees for about 15 seconds, and then you put the head up for the next 30 seconds. Now, if you compare to the standard way of doing Valsalva maneuver, there is an increased incidence of conversion with the modified Valsalva maneuver. A difference between like 43% versus 15% from the standard. So that's one thing that you can do prior to, say, giving drugs for narrow complex tachycardia. So let's move on to the next.
Can I just ask you how to blow into a syringe means? How is that again? The end of the syringe that attach the needle?
No, don't put the needle in, obviously.
Yeah, that's right. Of course.
It's just the syringe. Blow to the narrow end and try and blow the plunger out. Yeah. The idea is actually to elicit a Valsalva maneuver. So you can do a balloon as well if you like, but the syringe is something that we have available.
You can actually close your nose and your mouth and try to blow it out. Like you try to equalize during when you're on the flight. This Valsalva maneuver is useful, especially when, let's say, you're doing locum in a clinic, or when you're in ER and you're waiting for your consultant to come. It is a very useful method to teach the patient for you to explain. So you need to know how to explain to the patient. Okay, next slide, please.
So the first line drug for narrow complex tachycardia is actually adenosine. But it may be considered for unstable SVT while preparing for cardioversion. Occasionally, if you think that a wide complex tachycardia is still due to SVT, this is a little bit something that we didn't discuss very much the last time. So you can give adenosine to try and see through this possibility. Certainly, adenosine does not convert atrial fibrillation or atrial flutter or ventricular tachycardia. So if it converts, then you may actually consider that it might be SVT. So it can be a diagnostic maneuver in stable, non-narrow complex SVT if you're trying to determine whether this is a AV reentry or AV nodal reentry compared to, say, atrial tachycardia. With atrial tachycardia, it doesn't terminate usually. Okay. Next slide.
Yeah. Go on.
You wanted to add something? Yeah.
No, I just wanted to say that adenosine is actually very safe drug to use, right?
Yeah.
But I didn't realize, yes, it is a very useful.
Half-life is very short. It lasts for maybe 6 to 8 seconds. It's metabolized by the red blood cell. So it's a very short half-life and it's very safe. The precautions are that it causes this flushing or chest pain, sometimes a brief episode of asystole, bradycardia, and atopy following the injection. So you need to expect that. It is less effective in people who have taken theophylline, for example, or who just had some caffeine. You might find that those people who are very anxious and excitable, it tends to be less effective in those situations. If used for VT, it may cause worsening of the clinical condition. So if I would suggest that you should not use it in people with broad complex tachycardia. There will be a transient period of sinus bradycardia or ventricular atopy after the termination of SVT as well. And you could expect that, yeah. So, and it is safe in pregnancy. So you can even use it in pregnancy.
Is it contraindicated in asthmatic patients?
It is not actually, because the effect is very, very short acting. But if the patient has poorly controlled asthma, you probably should not use it. But if it's a history of asthma, you can still consider it.
And would you use it on like any routine where you need to inject it really fast, followed by a very fast, flushing?
Yes. Let's go to the next slide. It will describe that.
Oh, yeah. Sorry. Okay.
So the dose is You put the patient, before you gave the injection, you place the patient supine or mild reverse drenaline burp, because they might actually go briefly asystolic or brady. And you want to give 6 milligrams, which is the initial dose, rapidly. It's almost like a bolus injection, followed by a 20 ml flush. You can actually repeat this very quickly. You can increase the dose to 12 milligram every 1 to 2 minutes if the first 6 milligram is unsuccessful. So you can actually repeat this if several times if you wish, but generally speaking, we tend not to do so actually. Okay. So the alternative to adenosine is in the next slide. Now, verapamil is a very old drug. It's a calcium channel blocker, right? It is still one of the IV drug that is available for such purposes. In some centers or maybe overseas, you'll find IV diltiazem as well. So they act in very similar ways. Verapamil is a non-dihydropyridine calcium channel blocker. So it can control ventricular rate in AF or flutter. So that's the other indication. But if SVT is not terminated by adenosine, you can try verapamil if there is adequate blood pressure. Because verapamil lowers blood pressure, you need to be wary if the blood pressure is lowish. Okay. In that situation, you may want to consider cardioversion. Okay. Now, the contraindication would be do not use with wide complex tachycardia. Avoid them in known Wolff-Parkinson-White syndrome, particularly if they present with atrial fibrillation. Now, the reason for this is in Wolff-Parkinson-White syndrome, you have conduction antegradely from the atrium to the ventricle through the accessory pathway. So when you have atrial fibrillation, and if the accessory pathway can conduct rapidly, by giving verapamil, you're blocking the AV node. And in that situation, you're actually making the situation worse by having all conduction going down the accessory pathway. And that may actually induce ventricular fibrillation. You need to avoid in such situations. So you want to avoid it in AV nodal blocks as well. So probably in patients with, presenting with AV blocks, you don't want to be using it. And you have to be aware that it lowers blood pressure and therefore by causing peripheral vasodilatation.
And also in patients with heart failure, let's say a patient that you have known with very poor LV function comes with SVT. Yeah, you would like to think twice about using a verapamil, especially if the BP is low. Okay, so that's also a problem there.
When your blood pressure is low, you should categorize them as unstable, and in that situation, cardioversion is a better therapy.
Yes, which we will discuss later.
So the dose of verapamil is 2.5 to 5 milligram IV bolus, but given slowly over 2 to 4 minutes. And you need to have this patient monitored all the time while you're actually giving this IV verapamil. Because verapamil can cause AV block, and the AV block may be actually prolonged, and it may cause deterioration in your patient's signs actually. So a dose of 5 milligram can be repeated every 15 to 30 minutes until a dose of 20 milligram is reached. Now, the better way of giving IV verapamil is through an infusion. So you give an infusion at a rate of 1 milligram per minute until termination, then you stop the infusion, or until the total dose of 20 milligrams is reached. So that's a lot better, a lot safer actually, rather than give bolus doses. Betty?
I think the bolus doses are given like slowly.
Yeah, you need to give it slowly.
Like one, maybe not 1 milligram per minute, but just very slow bolus doses. And once it terminates, you can stop. You don't have to give it like, just because you prepare.
Yeah, correct.
Yeah,
that's right.
Yeah. Let's go to it.
Now, if you are faced with people with broad complex tachycardia, and in general, broad complex tachycardia should mean ventricular tachycardia. And in that situation, it is considered an emergent condition because the patient can develop ventricular fibrillation at any time. So in that situation, usually you hardly use IV drugs. You tend to do cardioversion or defibrillation. But in some situation where the patients are stable, you can consider IV drugs for the termination of ventricular tachycardia. Miodarone prolongs the action potential duration. It also prolongs the refractory periods of all cardiac tissues, and it decreases sinoatrial as well as AV nodal conduction. So it's got a broad effect on the myocardium. So the indications would include life-threatening dysrhythmias in people with ventricular fibrillation that is unresponsive to shocks, or in people with recurrent hemodynamically unstable ventricular tachycardia. But for any other users, for example, if you think that you want to use this in, say, narrow complex tachycardia, I would suggest that you seek a senior's opinion before you consider it. Okay.
And
Next
the
slide.
reason is because,
The reason is the amiodarone is toxic, and you don't want to be giving a toxic drug for long periods of time, actually. Now, amidarone's contraindication includes severe bradycardia, second or third degree AV blocks, and you do not want to administer amiodarone with medications that prolong QT interval. And there are a number of drugs that can prolong QT interval. So be careful. Right? The doses, if it's VF and VT, is 300 milligram IV in 20 to 30 mils of normal saline. And you can follow the first dose with 150 milligram every 3 to 5 minutes, and if needed.
how much of amiodarone do you use to load for a day or two, usually?
In a patient who terminates with amiodarone and you're going to use amiodarone long term, you need to build up the dose because amiodarone has got a very strong the tissue binding, especially in the adipocytes. So the dose, the levels, the blood levels are actually very low. You need to feel the adipocytes first before you get adequate doses. So usually you need to actually give up to 6 grams of amiodarone before it is then going to be, the loading dose is going to be complete. So usually I would tend to give 1 gram per day, 1000 milligram per day for a number of days, 5 to 6 days before I switch to 200 milligrams twice a day or 200 milligrams daily. But generally speaking, drugs is not the main way of treating ventricular tachycardias. So they are adjuncts, but they're not the main way of treating them. Okay. We will get to the therapies later. Now, ignocaine is a very old drug. In fact, a lot of people do not use ignocaine very much. They tend to prefer IV procainamide. But IV procainamide is not available in our pharmacy. So we have IV lignocaine. Lignocaine decreases depolarization and automaticity and excitability of the ventricles during diastole by direct action. And the indication, therefore, would be it's an alternative to amiodarone in VF and VT arrest. If you have stable monomorphic ventricular tachycardia, or you have malignant PVCs, PVCs that seem to induce ventricular fibrillation, because it acts on automaticity, it can reduce the PVCs. So it can be used in people who are suspected of Torsade as well. Torsade as the cause of ventricular fibrillation because it can stabilize the membranes, the myocardial membrane.
Nizar, can I just ask you, the last time lignocaine used to come in a syringe, available in syringe, right? Now
Correct,
they are It's no longer available, right?
Correct, yeah,
Usually,
that's not easily available.
yes, the preparation is different now. We use the lignocaine that we use for local anesthesia now.
Yeah,
Is
there
it?
used to be a bottle as well that you
Yes.
use for infusion. That too, I think, is not easily available these days. But IV lignocaine is still available.
And it is the LA that we use, right?
Yeah, it is still the same local anesthetic that we use actually.
Yeah, we just withdraw it and we give it.
Yep, it's still,
Okay.
we'll talk about the doses, right?
Okay.
Now, it is probably not advisable as a prophylactic use in acute mitral infarction these days because it raises the defibrillation threshold. And if patients were to go to VF, you might find difficulty reverting them to sinus rhythm. You need to reduce the maintenance dose in liver impaired patients because lignocaine has quite a narrow therapeutic window as well. The doses are 1 to 1.5 milligram per kilogram. So in a 70 kilogram person, you need 70 milligrams. You can also use this endotracheally 2 to 4 milligrams per kilogram. And in a refractory VF, you can actually give it in 0.5 to 0.75 milligram per kilogram in 5 to 10 minutes. The maximum dose is 3 milligrams per kilogram. Now, the maintenance infusion is 1 to 4 milligram per minute. But you will have to monitor them very closely because you may actually cause toxicity to occur. And the lignocaine toxicity presents with seizures actually. So especially in the elderly and the liver impaired, you need to give them the lowest dose possible to try and prevent VTVF.
Sometimes if you're not sure when you're new, always start with the lowest dose and you still see, let's say, the VT coming out, even if it's shorter periods, shorter duration, just increase it slowly. After some time, you will be very comfortable with using a lot of drugs that you are not familiar with.
Okay. So then magnesium sulfate, right? Now, it is indicated in patients that may have Tosat, which is suspected as the cause of the cardiac arrest. And life-threatening ventricular dysrhythmia in digitalis overdose is also useful in that situation. It causes a fall in blood pressure with rapid administration. So you need to give it slowly as an infusion rather than a bolus push. And you need to use caution when in patients with renal failure. So the dose is for cardiac arrest is 1 to 2 grams over 5 to 20 minutes. For Tosat with pulse, for example, you need to give 1 to 2 grams over 5 to 60 minutes.
And how effective is magnesium sulfate in the treatment of ventricular tachycardia, arrhythmias?
If it's due to hypomagnesemia, it is useful. But you need to look at the calcium levels, the potassium levels as well, because those would be primarily the cause of such arrhythmias as well. So if you find that both calcium and potassium is normal, then you may suspect magnesium as hypomagnesemia as a cause. You can try magnesium sulfate actually.
I didn't realize that it can cause a fall in blood pressure. Should I go
It
to
does.
the next slide?
Sure. Okay.
Yeah.
We are going to move on to the acute management of atrial fibrillation. Okay. So now the big difference between SVT and atrial fibrillation is actually the irregularity of the RR interval as well as the undulating baseline that you cannot discern any P waves. So this is a typical case of a rapid atrial fibrillation. Okay. Now, in people with acute AF, next slide, you should consider for all patients with fast AF, evaluate for underlying cause, and you should treat appropriately. So this may include chest infection, particularly pneumonias, hyperthyroidism, dehydration, myocardial infarctions. Patients who have chronic obstructive pulmonary disease may present with rapid AF. Hemorrhage and medication errors, for example, poisoning or alcohol intoxication, can all present in acute atrial fibrillation. So the initial investigations that you should send off would be whole blood counts, a venous blood gas for all. You may want to consider thyroid function tests, liver function tests, a chest X-ray if this is a new atrial fibrillation, and the additional tests will be required depending on the conditions. Okay. Next slide. At the back of your mind, you need to know the cautions and the contraindications for certain antiarrhythmic. For example, a miodarone. Firstly, because all antiarrhythmic drugs are negatively inotropic, especially in combinations. So I suggest that if you're not very familiar with it, then check the British National Formulary for Drug Interactions or whatever you use, Medscape drugs, for example, for drug interactions. But it's good to remember that imidazole, for example, should be used with caution and may be contraindicated in people with sinoatrial block, conduction disturbances, severe hypotension, patients with thyroid disease, congestive cardiac failure, pregnancy, and breastfeeding. Flecainide, which is another drug that is commonly used, should be contraindicated in patients with atrial flutter, congestive cardiac failure, structural heart disease, and recent myocardial infarction, because it increases mortality in these patients. Beta blockers, patients with asthma and COPD is contraindicated. People with uncontrolled heart failure.
Yeah. There was a study that actually showed that beta blockers can be used in patients with COPD. I think the study was yes, 2 years ago or so. Yes, but asthma, yes, I've had patients who, okay, sometimes all of patients I ask whether if they have history of asthma, but most times their asthma stops when they are a child. Maybe by 11 they would not have any more asthma attacks. So and then they need the beta blocker for certain reasons. But I have seen patients with acute exacerbation of asthma after not having it for decades, and then because I started on the beta blocker.
Mm-hmm. So it should be used with caution in people with, say, severe peripheral vascular disease, and probably contraindicated in sick sinus syndrome, AV blocks, or patients who are hypotensive. The same with calcium channel blockers, as you mentioned before, with people with heart failure, hypotension, sick sinus, heart blocks, AF with WPW, ventricular tachycardias, and pregnancy and breastfeeding, because it is actually passed through. It passes through the into the breast milk as well. Next slide. So once you have that in mind, you want to know whether are there any signs of hemodynamic compromise due to the AF. The thing about atrial fibrillation is it's rare that patients with AF present with compromise. And hemodynamic compromise is more frequently due to underlying conditions, which should be looked for example, sepsis, hypotension, chronic LV dysfunction, acute myocardial infarction, when the patient presents with chest pains. If you're unsure, then you should seek some advice from your seniors. Okay. So if the patient is unstable, what do you do? Next slide. The only thing that you can do in unstable patient or unstable AF is to do a synchronized DC cardioversion. Okay. So once you make this decision, you say the patient is unstable, should try and reach to somebody more senior to you. You need to consider a call to the anesthetist, because in all patients for cardioversion, they should be anesthetized or sedated unless they are unconscious. So they need procedural sedations. Now, the way that you cardiovert them, the best would be to put the patch in an antero-posterior position, and you synchronize them with DC shock of 200 joules or 360 joules. Now, if you find that they are still in atrial fibrillation, then you might want to consider miodarone before attempting DC cardioversion again. So once they are cardioverted, then you have to make a decision with regards to where they should be admitted to, whether they should be admitted to a monitored bed or they can be in a general ward. Some of the things that you might want to consider is actually, if the person or the patient presents with acute coronary syndrome with ongoing chest pain, obviously they should be in a monitored bed. If they have changes on the ECG to show ischemia, and unless you have at least a 6-hour troponin which is negative, they should be monitored as well. And if the AF persists with a rate that is more than 130 beats per minute while you're giving the amiodarone, you need to monitor them as well. If they have ongoing anti-arrhythmic drugs infusion like amiodarone, obviously they need to be monitored. And if they remain hemodynamically unstable, then they should be monitored as well. And if their GCS is less than 15 post-sedation, you should then monitor them too. Betty, do you think anything to add?
At this point of time, what Nizar said the previous slide, let me just go back to this previous slide where Nizar said that AF seldom compromise the patient hemodynamically. So if you come and see a patient, always look for all nodes. If the all nodes and the patient is already in atrial fibrillation, and now the patient is in atrial fibrillation with the low blood pressure, the blood pressure is not caused by the atrial fibrillation. Always compare notes. It is very, very important to look for all ECGs, all notes, to see what was the condition of the patient before. So this atrial fibrillation is actually an ongoing thing. The patient now has hypotension because of something else. Okay, maybe it's sepsis, maybe it's an MI, maybe it's cardiogenic shock. Okay, so this atrial fibrillation has been there. So don't think of, oh, I must cardiovert this patient, because chronic and persistent atrial fibrillation is very unlikely you're going to be able to do anything. I think you must make decisions about other things as well. Okay, and then if you have atrial fibrillation that is very fast in rate, and the blood pressure is low, but you need to bring down the rate, always consider the good old digoxin. What do you think, Nizar?
We shall talk about that. We shall go to the next slide. Okay. Now, if the patient is stable, right, you must know whether this atrial fibrillation has been present for 48 hours or less. The reason for that is, if it's less than 48 hours, it is safe to actually cardiovert them to sinus rhythm, either pharmacologically
History
or
is very
logically.
important.
If they've been in AF or it is uncertain, you have to assume that it's more than 48 hours. Because if they are more than 48 hours, they have a tendency to form clots in the left atrium. And you do not want to cardiovert them because you may dislodge these clots and cause a stroke. So you need to anticoagulate them if they are either uncertain or if it's more than 48 hours. So next slide. So if, let's say, for example, they are stable, but they're more than 48 hours, you may want to consider rate control. Meaning you want to control the ventricular rate. If, for example, you find that this is not a new atrial fibrillation, they have been in atrial fibrillation before, and the rate has increased for some reasons, maybe sepsis, you want to control the rate as well. So what you do with rate, for rate control, if rapid rate control is needed, you may use IV doses, but in general, oral dose will be sufficient. You can use beta blockers. I usually reach for beta blockers first,
Yes,
and
I love
either
beta blockers.
bisoprolol, metoprolol can be used. If it's metoprolol, you give it in 25 milligrams twice a day or PDS. Alternatively, you can give calcium channel blockers, especially the non-dihydropyridine calcium channel blockers like verapamil and diltiazem. Now, verapamil is given in a dose of 40 milligrams 3 times a day per oral. You can give IV verapamil as well, but the cautions that I mentioned before still stands. That is, if you're hypotensive, then you probably don't want to give IV drugs. If you're discharging them on you might as well use diltiazem 120 milligram for rate control rather than verapamil, because
Okay, I like to say, yeah, I like to stop you here, sorry, to interrupt you for a while. But I think that if you can use beta blocker, I think that is my first choice always, unless there's a contraindication compared to calcium channel blocker. And I think if you need to control the rate quite well actually, because sometimes they are at rest, their rate is very easily controlled. It is when they exercise, then their rate goes up, and then the effort tolerance is, they can't improve on the effort tolerance. So I find beta blocker more useful than others.
So because they are stable, right, you don't, they're not
Right.
urgently necessary for them to control the rate. It doesn't have to be very quick. But metoprolol acts pretty fast as well. So within 24 hours, 12 hours or so, 12 to 24 hours, you should see the heart rate starts to drop. And you can then titrate the dose to control the rate. Now, I usually use digoxin in the elderly people, or as an add-on to either metoprolol or verapamil. But if you use digoxin with verapamil, you have to realize that they interact. They tend to increase the effect of each other actually. So you need to probably start at a lower dose for digoxin if you use verapamil. Especially digoxin may be useful in elderly that are their mobility is limited, or if they have congestive cardiac failure. If in patients,
Anything else you want?
if they are hemodynamically unstable or shock resistance, then we want to try and use imidazole to control the rate as well. It's possible to use IV imidazole to control rate. Now, the other thing that you need to consider, because this is rate control, is to anticoagulate these patients, right? Now, anticoagulation is indicated if there is a score called the CHETS-2-VASc score, and if the score is 2 or more, they should be anticoagulated. You need to consider a score of 1, and if the patient is male, if the patient is female, if a score of 1, you still need to anticoagulate actually. Now, if the Hasblad score, which we will be discussing in the next slide, is the score to estimate the risk for bleeding, because when you use anticoagulation, there is a risk for bleeding. So let's look at if the Hasblad score is more than 3, then probably you need to discuss with your seniors before you start anticoagulation. Anything to add, Betty?
No, I am not familiar with the scores at all. I'm sorry to say that, but I usually would anticoagulate patients the moment I see them, at least an antiplatelet. And if I cannot get a history of the duration of the first onset of atrial fibrillation, I would then assume that they do have blood clot, and then I would at least put them on some low molecular weight heparin before, let's say, during that time that they are admitted, and then before I decide what is the long-term plan and what kind of anticoagulation I'm going to look at. Because if this is a first admission, first time, and unable to identify the duration, I would just, like you say, if take it as more than 48 hours, take it as there is a possible clot in the LA appendage, and then start on some antiplatelet, especially if the LV function is good, it is not valvular, and then after that, and there's no harm in starting this low molecular weight heparin because it is short acting, it is useful. Okay, but let's go to this scoring system. I'm sure everybody would like to know about it.
Okay, the chest vest score stands for each letter in the chest vest stands for a certain comorbidity actually. So the C is a history of CCF, that is 1 point. A history of hypertension is 1 point. Age, there are two age here, so that's why there is a 2 after the age, right? The first is anyone above the age of 75 has an increased risk for thromboembolism. The score is 2. But if they are between 65 to 74, their score is 1. If they have diabetes mellitus, the score is 1. If they have a previous history of stroke, the score is 2. Stroke or TIA. And if the patient is a woman or a female, that itself is an increased risk. The score is 1. Well, the Hasblat score,
female increased risk of stroke.
Correct. Yeah.
Something new. Yeah.
Anything above the age of 2, the score of 1, there is already an increase of risk for stroke. So the risk increases with increasing score numbers actually.
Okay.
Now the Hasblat score, on the other hand, also are comorbidities. You will see that they interact actually. So a history of hypertension increases the risk for bleeding. If you have abnormal renal function or abnormal liver function, they increase the risk for bleeding. The score is 1. If you have a previous history of hemorrhagic stroke or any stroke, the score is 1. If there is a history of bleeding, like a GI bleed, there is an increased risk for bleeding. The score is 1. Because this Hasblat score was actually done on patients with warfarin, if they have a history of labile INR, that constitutes a score of 1 as well. Anyone above the age of 65 has an increased risk, and if they're on drugs like aspirin or they use alcohol, the score is 1 for each of the drugs and alcohol. So any score above 3 suggests that there is an increased risk for bleeding.
Basically, what we're trying to say here is we need to
balance the risk. Yeah, balance
but
the risk.
So balance. Finding a balance is quite difficult. And now we go to the next slide. We need to go faster, Nizar.
Sure. Now, if a patient has
hour.
got, they're stable, you can actually choose between rate and rhythm control. The people who you would want to consider rhythm control, that is to try and get them back to sinus rhythm as soon as possible, are those who are symptomatic of the atrial fibrillation. And if they're young, young meaning less than 65, or this is their first episode of acute AF, and therefore you want to try and get them back to sinus rhythm because they may maintain their sinus rhythm for long periods of time if you get them back to sinus rhythm. So if symptoms and signs of heart failure or structural heart disease, then you should request for an urgent echo. But otherwise, echo is not required at this juncture. The treatment would be cardioversion if it's something that you want to consider. But you can also consider oral flecainide 300 milligrams orally as a single dose or a miodarone infusion at 125 milligrams per hour until conversion, or 3 grams maximum. So
We used to use oral propafenone, but that's not available anymore, right?
yeah,
600.
you can't get propafenone. So flecainide is the alternative actually, 300.
300. Okay.
Yeah.
So we go on.
So in patients who you want to attempt rhythm control as well, if they're less than 48 hours, you can do so immediately. But if they are beyond 48 hours, then you need to start anticoagulant for 3 weeks before you consider rhythm control or getting them back to center. Okay. We'll move to cardioversion and defibrillation. Next slide.
Okay. We have spoken for an hour, so there's no time limit. There's no time limit because this Zoom, I've paid for it. The thing is that, yes, yeah.
Can you go back one slide, Ben?
Yeah, sure.
Now, what's the difference between defibrillation and cardioversion? Defibrillation is the non-synchronized random administration of shock during a cardiac cycle, while cardioversion is a synchronized administration. So it is not, even if you're in atrial fibrillation, that's cardioversion, not defibrillation.
Yes.
Electrical currents travel from the negative to the positive electrode by traversing the myocardium, and it causes all the heart cells to discharge simultaneously, and that interrupts and terminates the electrical rhythm, and that allowing your normal rhythm to come true. Next slide. The indications of cardioversion or defibrillation is defibrillation if you have ventricular tachycardia or ventricular fibrillation. In the indication for electrical cardioversion is supraventricular tachycardia, atrial fibrillation, and atrial flutter. You may consider ventricular tachycardia with pulse as a cardioversion as well. Next slide. It is contraindicated in dysrhythmia due to enhanced automaticity, such as digoxin toxicity or catecholamine-induced arrhythmias. Because in this situation, there are automaticity, so you cannot disrupt the circuit. It may just come back. In multifocal atrial tachycardia, this is a typical case of automaticity. It is contraindicated. You need to control the rate for that purpose. Next slide. So this is the defib pad position. In the anterior-posterior position, the anterior pad is to the right of your sternum and center it on the fourth intercostal space. And the posterior pad is at the level of the 7th vertebra, right, paravertebrally, and you center it at that place. Right? While the anterior apical position is similar as the anteroposterior position, the anterior lead, but the apical lead is placed in the mid-axillary line in the 5th or 6th intercostal space. Okay, next slide. So for elective procedures, you probably need to prepare as follows. The patient should be nail orally for 8 hours, 6 to 8 hours prior to the procedure. You should stop digoxin for 8 hours prior to the procedure as well. The energy requirements are for AF 100 to 200 joules. Atrial flutter is less. Yeah, atrial flutter is lower because in cardioversion it's lower. Atrial flutter is 50 to 100 joules. For ventricular tachycardia is 100 joules, and for ventricular fibrillation is 120 to 200 joules biphasic shocks. Now the complications of cardioversions include you may actually induce ventricular fibrillation, and you need to prepare just in case you do, you need to cardiovert them or defibrillate them. You may cause thromboembolism, that's why in AF you need to anticoagulate them. You may cause myocardial necrosis, and you may cause transient myocardial dysfunction as well. And occasionally you may cause pulmonary edema in people with diastolic dysfunction. And you may actually cause painful skin burns as well. But this is less likely if you use the patches rather than the gels. Next slide.
But of course, most times it's a life-saving thing that we do, right?
That's
So
right.
don't be,
So in
yeah.
life
And
saving, you don't need sedation. You don't need to call the anesthetist. You need to give the
because
shock immediately. Yeah. So the first thing you do when you are faced with ventricular fibrillation is to start CPR, right? Get somebody to get the defibrillator, put the patches on, and defibrillate if the patient is still in VF. You need to defibrillate 3 times before you restart CPR because you want to try and get the patients back to a stable rhythm rather than ventricular fibrillation. So we're going to the last group of things. This is just for interest. The electrophysiological procedures. This include
now sometimes
temporary
it's more
pacing.
than,
Oh,
sorry. Sometimes
go to the next slide.
it's to understand this procedure is not just because you need to know, but because most times the house officer will take consent. So
Yeah,
you need to explain to the patients, you know. You can't explain to patients if you don't know what is a pacemaker, what is an electrophysiology study, and what's a. So we would go briefly through it, and then so that you can take a good consent, okay.
is that still
Um,
true? I thought the consultant should take consent.
I know. I think we used to take consent. I'm sure they have to take consent. Yes, it is important to document the consent, and then you need to understand all this. Yeah, let's go through some of it.
So the first are temporary pacing or bradycardias. Now, those drugs that you use in, say, AV blocks, for example, the third degree AV block, are temporary. You want to use temporary pacing, transvenous or transcutaneous. Transvenous as a bridge to permanent pacemaker because they are more stable and more comfortable for the patient. Then the permanent pacemaker, there is such things as single chamber, dual chamber, as well as transvenous intracardiac pacemakers these days. And cardiac ablation is a way of actually treating arrhythmias. And you can divide them into radiofrequency and cryoablation. Next slide. So, temporary pacing. Now, cardiac pacing is indicated primarily for treatment of bradycardia. So you have transcutaneous pacing. It's employed first in an emergency, followed by transvenous placement of a ventricular lead, allowing a longer period of pacing and evaluation of patients who then may require permanent pacing later, right? So you may also use a temporary pacemaker to overdrive pace. That is, it means you can use the pacing as an anti-tachycardic treatment of a variety of atrial and ventricular tachycardias, particularly those circus movements or re-entry tachycardias, such as post-operative atrial flutter and monomorphic ventricular tachycardias.
Basically, if you have a basically if you, let's say a patient comes in with bradycardia, you put in a temporary wire, and then the patient went into, let's say, fast tachycardia. I mean, a fast rhythm. You just increase the pacing to a higher level of what you see on your monitor, and you can actually control it better. You'll
Yeah.
go back to, yes.
So particularly in those situations that when you cardiovert, they go back to tachycardias quickly, you know, or when you give them drugs, they keep on going back to getting tachycardias. So in that situation, sometimes putting in a temporary wire and do anti-tachycardic pacing is more comfortable for the patient. Pacing can also be used to prevent bradycardia-dependent tachycardia such as torsades. So that is the other indication for temporary pacing.
Oh, yeah, that's an interesting note that,
Yeah.
okay.
Okay. Next slide.
I
Now,
think this one tak payah.
Tapaya, because
Tak payah.
they will always know that there is something called VVI, DDD, and all sorts of pacemakers.
Okay, okay, go on.
There is such
Briefly.
thing as a pacemaker code briefly, right? And it comes in 5 letters. So the first letter is the chamber pace. So it may be A, V, or D, or O. The second is actually the second letter. It stands for the chamber sense. So this can also be O, A, V, and D. D standing for dual chambers. The third letter stands for the response to sensing. So it can either be none, triggered, or inhibited. And the fourth usually stands for rate modulation. So an R is where there is rate modulation and O is none. And finally, the fifth letter is for multi-site pacing. These days, you have devices that are used not for pacing, but for heart failure. And they may have two ventricular leads actually. So if it's a single chamber pacemaker in the ventricle, you call that a VVI pacemaker, right? The pace, the first letter is V, the sense chamber is also V, and when it senses, it actually inhibits. So when there is a normal beat, it inhibits the pacemaker, right? So that's a VVI pacemaker. You might find that in quite a number of patients, they have what we call a DDDR pacemaker, which means they have two leads, one in the atrium and ventricle. Both atrium and ventricles are sensed, and they usually triggered and inhibited as well. And they are usually rate modulated. Okay. So next slide.
Hold on, yeah. Okay.
So this is what you see in a person. It's the same machine that you use for cardioversion that you use for transcutaneous pacing, right? The patch is the same as well. So you can put them in the anterior apical position or the anterior posterior position, the same position I mentioned for cardioversion. But rather than defib, you actually use them as a pacemaker. Now, they usually require high voltages to capture the heart. So you will see
it can be very uncomfortable for the
it's
patient,
uncomfortable, but at least it's a bridge to temporary venous pacing actually. So you want to use it to save the patient and then to get them to the cath lab to put in the temporary wire. So the next are what we use.
When you don't have a cath lab and you need to transfer the patient, that is also very useful.
That's right, yeah. Next slide. It'll show, the next slide shows what we use for transvenous pacer. So in the right-hand picture there, you see the bipolar leads. The bipolar leads is actually introduced either through the subclavian vein or the femoral vein, and then they're threaded up into the ventricle. And the middle picture is the connector. The connector connects to the generator, which you can try and use as a pacemaker. So this is a dual chamber permanent pacemaker. The pacemaker is implanted at the shoulder under the skin, but you have two leads that are essentially introduced into the subclavian, the left subclavian vein, through the nominate and the SVC, and it ends up both in the atrium and the ventricle. So you use the permanent pacemaker for those patients who have a permanent cause for AV blocks. So the next picture, the next slide, is an example of a dual chamber pacemaker. So you have two leads, and both these leads at the moment are screw-in leads, and they're connected to the pacemaker, which generally determines does the sensing as well as the pacing as well. Okay. So what do you get when you see ECG with a patient in a pacemaker? So here is an example of a pacing ECG. You will see a spike before the either chamber is actually paced. Right? In this situation, you see a spike before the QRS complex. And if you see such a pace ECG, you know this is a VVI pacemaker, which is pacing in the ventricle. You might notice that there are no P waves here, so the patient is probably in atrial fibrillation as well. Next slide. In this ECG, you notice that there are two spikes. One precedes the P wave. You can see it in AVF, you can see a P wave there. And the other spike precedes the QRS. So you know it is capturing both the atrium and the ventricle. Therefore, this is a DDD pacemaker. Right?
And this pacemaker is more physiological compared to, let's say, because just a VVI pacemaker.
Yeah. So it's physiological because the the pacemaker acts as the AV node, right? Here is an example of a single chamber pacemaker in the atrium. So you see the pacing spike before preceding the P wave. So this pacemaker is in the atrium, and conduction down the AV node is rather prolonged, but you see a QRS complex after each P wave. So there is a first degree AV block, but this is an AAI pacemaker.
Yes, basically pacing the atrium because maybe the patient has 6 sinus but no block.
Okay. So we're getting close to the end of this talk. I'm just going to tell you a little bit about what catheter ablation is. In radiofrequency ablation, you use a catheter that is introduced from the femoral vein into the heart. So you notice that the ablation catheter is abutting against the myocardium. When you actually introduce radiofrequency energy, which is a current that has 750 hertz, it actually is conducted through the body, through the myocardium, through the body, and through a patch that is placed on the patient's back to complete the circuit. What happens is, when current travels through resistance, it produces heat. And it is not the catheter tip that actually becomes hot, but the tissue that heats up. And usually, the tip of the catheter, there is a sensor, a temperature sensor. And therefore, it will be able to monitor the tissue temperature. So you modulate the tissue temperature to reach 60 degrees centigrade to cause a permanent change in the tissue itself. You know that at 60 degrees centigrade, proteins will tend to coagulate, and you will cause a permanent change. Now, the lesion that is produced is usually only 3 millimeters in diameter. You need to be precise, and therefore catheter ablation is typically suited in cases for supraventricular tachycardia, either involving the AV nodal reentry tachycardia or accessory pathways. Okay. So the next slide, it will show you an example of what we do. In the first panel on your left, you see a delta wave preceding the QRS, right? And right in the top, you see 3 ECGs, lead 1, lead 2, and V1. Now, the next few panels, the next few lines are based on the catheters we place inside the heart. And we receive signals from IRA, which is the high right atrium, the HB is his bundle electrograms, the right ventricular apex, the RVA, the ABL stands for the ablation catheter, so that's signals coming from the ablation catheter, and you have catheter in the chorosinus as well. So you notice that when the RF ablation is turned on, that is the panel in the middle, right? After 2 beats of normal beats, you find
Okay, I would like to stop. Okay, don't worry if you don't know
yeah,
this.
if you don't,
Don't worry if you cannot understand this because it's also beyond me. Nizar has tried to teach me many times and I cannot get it. It's a bit difficult because it's not something that you can you see often in
you concentrate on
yes.
lead 1, right? You see the delta wave in the first 3 electrograms. First, second, third, and the 4th electrogram, you don't see the delta wave anymore. You see that it's being ablated, right?
Oh, I see.
You can see that. You don't see the delta wave now. So you notice that in the last panel is where the ablation catheter is.
Okay.
ABL
So I
stands
can tell
for
you.
ablation.
So the delta wave is the upstroking.
Right.
Okay, here, especially. Okay, then now you don't see it anymore because it's ablated.
Because you are delivering current through the ablation, and that's where the accessory pathway is. That's an example of what it is.
Yes. Okay, we
Next
go
slide.
on. Okay.
So the catheter ablation is indicated in supraventricular tachycardia, especially AV nodal reentrant and Wolff-Parkinson-White. You can also use it in unifocal atrial tachycardia and atrial flutter. In these 4 conditions, catheter ablation is first-line therapy. So you don't need to think of drugs. This should be the treatment for
Because it's a
patients.
cure.
Yeah. Now, atrial fibrillation with lifestyle impairing symptoms and inefficacy to drugs or intolerant to antiarrhythmic drug agent are also an indication. So both left atrial ablation for restoration of sinus rhythm and AV junction ablation for rate control can be done by catheter ablation. Sometimes in symptomatic VT, you can, catheter ablation is first line in idiopathic VT. But in structural heart disease, it is an adjunct to, say, drug and ICD implantation. ICD is the mainstay of treatment there. Next slide. The uncommon indication for ablation is symptomatic drug refractory idiopathic sinus tachycardias, lifestyle impairing ectopic beats, for example, and symptomatic junctional ectopic tachycardias. These are rare instances where catheter ablation can be curative as well. So just an example of how we do AF ablation these days. Now, the majority of patients with AF, they have a focus. And invariably, the focus lies in the pulmonary veins. We know that the heart has got at least 3 or 4 pulmonary veins. So what you do with the pulmonary vein, in atrial fibrillation is you isolate the pulmonary vein rather than ablate within the pulmonary vein focus. Because when you do so, when you do radiofrequency ablation in the pulmonary vein, you can cause pulmonary vein stenosis, and that may cause pulmonary hypertension. So here is an example of what cryoablation does. You have a balloon that you introduce through a transeptal puncture, which means through the atrium, septal wall. And then the balloon is used to plug the left superior pulmonary vein in this instance. And then you have liquid nitrogen pumped to the anterior portion of the balloon. So you see that it becomes pure white, and that reduces the tissue temperature to less than minus 55 degrees centigrade. And what it does is actually it freezes the tissue and it causes crystallization or ice formation in the cells. And that causes the death of the cells. And you create a scar that encircles the pulmonary vein, therefore preventing the focuses in the pulmonary vein influencing the heart and causing atrial fibrillation.
It reminds me of a movie in what you call it, in Netflix, where they stay in a train and outside is really, really cold, and then somebody's. Have you seen that show? I don't remember. I don't remember the name. Okay, so yes, because the temperature, right? The next slide.
Yeah.
Sorry, I've been going back. Yeah. Okay. I think we should.
Just to tell you the efficacy and complications of catheter ablation, right? Now, for SVT, the success rate is usually more than 95%. For atrial flutter, it's more than 90% curative, actually. For atrial fibrillation, it's up to 70 to 80% success. For ventricular arrhythmia, particularly, say, PVC focuses, it's more than 80%. The complications can be an issue though, but it's usually very low. It's less than 1%. Thromboembolism, cardiac tamponade, AV block can occur, but generally speaking, it's less than 1%. So
it is
that is the final slide. Yeah.
Common, yeah, that's the final slide. Is there any questions? We take questions now. You can either unmute yourself or you can key in your questions by putting in the chat. Let's unmute, let's say, Tan. Tan? Where's Tan? Ask for video and unmute.
Yes.
Tan, yes. Anyone can actually unmute and ask questions. I think Nizar has given. Where is Nizar? How come I
I'm
can't
here.
see
I'm
Nizar?
still connected.
Okay, I stop share then. I think Nizar has given a very comprehensive thing about the treatment of atrial fibrillation, and I think it is very important that it is very difficult to practice medicine without practicing medicine. If you just study it, it's difficult to remember. But once you start practicing medicine, then you will start remembering what we say. Then it's easier to apply. I think Chin Wing Yuan said, "I'm sorry, I just didn't catch the one part. What is the
Okay.
significance of atrial fibrillation? Is it less than 48 hours or more than 48 hours in terms of management?" Okay.
It,
Basically, we are not talking about atrial fibrillation's management in the sense of changing the rate, but more in the sense of whether we should revert the patient back to normal rhythm or not. The 48 hours is a cut-off point because if the patient has developed atrial fibrillation more than 48 hours, then we should not cardiovert or revert the patient back from atrial fibrillation to normal rhythm without thinking of anticoagulating them. Because after 48 hours, they will have formed some amount of clots in the LA appendage. And if we cardiovert them or change them to normal rhythm, this clot will dislodge or may dislodge and cause a stroke. Nizar?
yeah, that is the reason. So if the patient has been in atrial fibrillation for more than 48 hours, you want to anticoagulate before you consider getting them to normal rhythm. And it will mean that if the patient is stable, rate control, and 3 weeks of anticoagulation before you bring them back for cardioversion or pharmacological cardioversion.
Does that answer your question? Um, Chin, do you think that you can get what we are saying? Oh, yes, okay. He says he understands it now. Thank you. Anyone else? Okay. Now, atrial fibrillation is extremely, extremely common. You're going to see it a lot, and you're going to see it a lot in patients that actually may only have one episode in their life. Okay, when maybe because they have sepsis, maybe because they have an MI, and then they recover fully from it. But always, once you have atrial fibrillation, the chances of you getting it is always higher. That's one. The longer you have it for, the more difficult it is to change you back to normal rhythm. And so, as much as you can, okay, get a very good history. Okay, try to determine the onset of the atrial fibrillation, and your decisions to treatment is basically based on that for the first episode. Okay, very important. That 48 hours will determine what you do or do not do for the patient. Anything else? Now we have had a very long session, 1.5 hours.
Oh, you.
Okay. Um, Tan said, how long does a patient need to be on anticoagulation after the first episode? Is it okay? If it's the first episode, I don't mind putting on the patient on lifelong cardioprin, but sometimes I just let it be, especially if they have underlying causes like sepsis. Then they recover from the sepsis, they recover and they don't get atrial fibrillation again. So the first episode is a very difficult decision to make when you have reverted them to normal rhythm, because it's very difficult to tell the patient that you may get another episode, you may not, we don't know when, you don't know when. Okay, and then the decision is difficult to make. Nizar?
Well, if let's say you have a reversible cause and the AF will not recur, then you might stop it after 3 weeks after the patient has reverted to sinus rhythm in a young patient, for example. But if there is no reversible cause and the patient is elderly above the age of 65, for example, and he has risk factors like diabetes and hypertension, the likelihood that it will recur is high, then I would continue anticoagulation indefinitely. In lieu of the fact that the Has blood score is low, the patient should be safe. Right? So it really depends on the risk of thromboembolism and stroke. And your CHEST score will help you with that.
It is very important to also look for valvular heart disease when the patient has gone to atrial fibrillation, because it is a very high risk for thromboembolism, especially if the patient has chronic rheumatic heart disease with mitral stenosis. Okay. Even if the patient has no atrial fibrillation but has chronic rheumatic heart disease with mitral stenosis and a biggish LA, always think about anticoagulation. Okay,
But in that
that's the
situation,
doctor.
yeah, in that situation, you must use warfarin.
Yes, you must use warfarin. There is no indication for
The new anticoagulant is only for
anticoagulation.
non-valvular AF.
Okay, Tan said, I'm sorry I've missed the first part. Can you explain again when to choose rate control over rhythm control? I'm so sorry, Tan. We can go briefly, but because you are late, we can't explain the whole session all over again. Basically,
You're gonna publish this again, isn't it?
yes, we're going to publish the slides. We're going to share the slides, and then we're going to share this on YouTube with under Beating Heart channel. You can watch it again, okay? And then you can message us for any because we are on Telegram. Join the Telegram group, and if you need to ask us, you can ask us there. Because if we were to explain everything to you again, it's it's a very
But
broad topic.
I can
Yes,
summarize.
you can.
Okay.
Yeah.
You would consider rhythm control in people who are young, relatively young, less than 60, first episode of atrial fibrillation, or they are symptomatic when they are in atrial fibrillation. So these are the three indications for rhythm control, actually.
Okay. Jared asked if patient has history of coronary artery disease or acute coronary syndrome, is there any difference in the management? If so, which should we take precaution on?
We're talking
Well,
about AF.
no, we're talking about AF. I think he didn't mention, but I think we're talking about AF with acute coronary syndrome.
Right.
Most times, acute coronary syndrome in itself present with a plethora of tachyarrhythmias, sometimes even bradyarrhythmias. And if they have atrial fibrillation, sometimes it's already because they have risk factors for atrial fibrillation, and therefore they have risk factors for ACS. For example, they're diabetic, they're hypertensive, they are of elderly age group. So these are all risk factors. So it is very difficult to say how we treat a patient, because every patient may be treated differently on the presentation, and also from what we get from the history of the atrial fibrillation. If let's say I saw the patient 3 days ago and he had no chest pain, no atrial fibrillation, he comes in today with ST depression, chest pain, and he's in atrial fibrillation, I can safely say that he just had the atrial fibrillation. It was brought on by ischemia, and then therefore, when I treat the ischemia, he may revert back, but I will also probably give him some miodarone to aid or ease this reversion. But treat the underlying cause always. Okay, Alvin said, anything you want to add to that ACS, Christian, Nizar?
If the patient has acute coronary syndrome, that is obviously the underlying cause of any arrhythmia he has, usually, right, acutely. and you should manage that urgently as well. It tends to complicate things if you have ACS and atrial fibrillation, because in one situation you do not want to, I'd say, you want to try and treat the patient quickly. You don't want to delay things. You want to do things like choreangiogram, and you might want to reperfuse the patient as soon as you can. But if the patient remains in atrial fibrillation following the acute treatment, then what we have discussed subsequently will stand. Therefore, you might want to consider rate or rhythm control, anticoagulation after, and that sort of thing.
Yeah, and it's also very important to try to control the rate of the atrial fibrillation during the ACS, because you already compromise and you have myocardial ischemia. Anything that increases the rate will worsen the ischemia. So rate control is also very important. I think we did not mention about TE in but I think we will talk about that later. We got questions coming in. Alvin asked whether,
How many doses?
how many doses of IV adenosine given with no response, then we should change to maybe verapamil. Or, okay, go on. I think you said that in
there's no limit actually, right? Because adenosine has very short half-life, 6 to 8 seconds. So you can repeat the doses as many. But usually what you should do, you give 6 milligrams, it doesn't work. You give 12 milligrams as the next dose. And if that doesn't work, I usually attempt a third time. And I usually give another 12 milligrams. If it still doesn't work, I will then revert to, say, IV verapamil.
yeah, and then Bhatia, sorry, okay. How do we know if that the patient has AF? That is where you have to take a very good history. Yes, we can know from the history most times. Okay, because
When did the symptoms start?
yes, when did the symptoms start? Okay, and sometimes this atrial fibrillation within 48 hours, they actually don't have the palpitation all 48 hours. They might have it intermittently. But when did the symptoms start? Okay, history is one of the most important part of our physical examination, and a good historian, okay, means a good doctor, okay, is part and parcel of being a good doctor is taking a very good history, a very good history. Always ask more. Okay, when did it start? When did you feel? Did you feel it before? Did you feel it a month ago? No, it just came 6 hours ago. There you go. 6 hours is where it started. Okay, and then you reconfirm by looking at the onus, whether there has been times when the patient has been in and out of atrial fibrillation, or has the patient been in sinus rhythm. Always compare notes. Okay, always look at all notes. Okay, that is part of your job. Okay, so she said, can we know from the history or able to trust? No, it's always from the history, and 48 hours is the cutoff point before we actually think of not cardioverting the patient or reverting the patient back to sinus rhythm. Yes, the patient, even if it's less than 48 hours, yes, there is a risk. Okay, and if the patient has valvular heart disease with atrial fibrillation of new onset, also think twice about the risk of thromboembolism. I think if the patient has valvular heart disease, you should treat atrial fibrillation quite differently. What do you think, Nizar?
Yeah. Well, the first thing you must decide is the patient stable? If the patient is unstable, the patient's blood pressure is 60 systolic, you don't want to be worried about anything else but get him back to normal rhythm if you think the rhythm is the cause of it, right? But if the patient is stable, then you want to try and mitigate the risk for strokes. And the 48 hours has been what we've used arbitrarily, obviously, but it's been used in trials to show that beyond 48 hours, there's an increased risk for stroke. And less than 48 hours, there is still a small risk, but that risk is manageable and it's probably acceptable if you want to consider getting them back to normal rhythm. You can choose not to actually cardiovert them, anticoagulate them, and then call them back in 3 weeks. But if there are reasons, the patient is symptomatic, you have explained the patient's the risks involved, then they still prefer to get them back to normal rhythm, you can actually do it. Alternatively, Dr. Betty has mentioned about transesophageal echocardiogram. That is an additional thing that you can do. What we do with transesophageal echo is we pass a small catheter down the esophagus. We looked at the heart from behind. There's a very thin wall that separates the esophagus and the atrium. Therefore, you should be able to pick up small thrombus much easier compared to transthoracic. So you can consider doing that. But the 48 hours is the standard that we use generally.
Yeah, I think at your point where you're going to start your career soon, you're going to see a lot of patients with atrial fibrillation. Always remember 48 hours is a very important cut-off point for you to decide on how to manage a patient. I think we have answered everybody's questions. We have had a very good talk and quite interactive. Next week, we are going through a few cases and I would like it to be more interactive. So next week, I think it is, I would expect maybe people to unmute and ask questions and reply some of the discussions that we are going to throw at you guys. So I'll see you next week. Thank you, Nizar.
Thank you.
Okay, see you, because I really need to do another live chat.
All right, then.
See you. Bye. Okay. Bye, guys.